So next we'll switch gears a little bit and talk about coronary artery disease and TAVR, impact on outcomes and when to treat. So the purpose of this talk, actually we have to understand that aortic stenosis and CAD are present in about 50 to 70% of the patients. Higher the age, the probably more concomitant coronary artery disease with aortic stenosis patients. The current gold standard of is to perform CABG with SAVR, yet TAVR is quickly replacing surgical aortic valve replacement in many subgroups of patients. How to manage coronary artery disease in this group of patients when TAVR is being done is still not very clear. And PCI is increasingly performed to complement TAVR. Outcomes and safety of PCI in patients with severe symptomatic aortic stenosis are largely unknown. So here is a case presentation, 90-year-old patient, hypertensive, hyperlipidemia, chronic kidney disease, and baseline creatinine 1.9, and history of low GI bleed in September 2014. Aspirin had to be stopped and patient had received 2 transfusions. And she was admitted with shortness of breath on exertion, no angina. Hemoglobin is 16.4, creatinine is 1.9. EF is 70%, severe aortic stenosis with mean gradient of 40 millimeters and aortic valve area of 0.9 square centimeters and LVOT diameter of 23 millimeters, mild MR and pulmonary artery systolic pressure is 34. So here's the angiogram. It shows LAD diagonal, multiple 70 to 90% lesions, mid LAD is 100%, occluded with the collaterals that you can see gradually filling up the LAD, and circumflex has a mid 60% disease. And the right coronary artery is okay with the collaterals from right to left. You can see the LAD is filling up very well now. And STS risk score is about 37.5 given the LAD CTO. So if you calculate STS risk score, I mean obviously STS is calculating for aortic valve replacement and bypass surgery. Here the risk of mortality is 7.8%, which is considered as actually intermediate risk score between 4 to 8 is intermediate, so more than 8 is severe. And the morbidity, mortality, permanent risk of strokes, all these are very high, about nearly 38% morbidity or mortality combined together. So here in summary we have 90-year-old male patients with symptomatic severe aortic stenosis, STS 7.8, and significant coronary artery disease, syntax score of 37.5, and occluded mid LAD, which is a CTO, severe LAD diagonal coronary artery disease, circumflex has a moderate lesion. And treatment options are surgery plus bypass surgery, TAVR plus or minus PCI, or medical therapy. I mean obviously we are in a TAVR session, we are going to talk about TAVR. So the questions are actually the patient has no angina, main complaint is shortness of breath. Does it impact your decision to proceed or not to with PCI prior to TAVR? So timing of the PCI, when should it be done? Should it be done in New York State, for example, if a patient dies after PCI, even though it is related? If I do a PCI today and the patient goes for a TAVR next day, and if the patient dies, both the interventional cardiologist and the structural interventionalist, if it is a separate person, they will be dinged. So the report card will be showing that it is a mortality within 30 days after PCI, and it is a mortality after TAVR as well. So some of the interventional cardiologists, they shy away from doing PCI prior to TAVR based on they don't want to get a bad report, because it's not related to them, but it is related to the TAVR mortality, but they still will get a bad report card. So should it be done before TAVR, during concomitant to TAVR, or after TAVR? And these are the questions that we'll have in our minds. PCI, do you perform a BAV prior to PCI, because of a risk of rapid pacing is what we are concerned about in patients with significant coronary artery disease. And what do you do with the LAD CTO in this patient? Do you treat a moderate circumflex lesion, or is it crucial to obtain complete revascularization to TAVR, and is there any data to it? And whether we should use bare metal or drug-eluting stent that this patient had a previous GI bleed, maybe bare metal stents would be better, we don't know. So here in this patient, we didn't do any BAV prior to PCI. 6-French XB 3.5 was used through the right radial, BMW wire in the diagonal, pre-dilated with a 2.0 into 15 balloon. And 2 integrity bare metal stents were implanted because of the history of GI bleed. And as he is 90-year-old, if he comes back with restenosis, then you obviously can do the DES in the future. And obviously post-dilated with the non-compliant balloon in the 3.0 into 15 millimeters in the proximal diagonal. And sorry, proximal LAD. So the LAD PCI looks okay. There is no, we didn't recanalize the CT of the LAD. And FFR of the circumflex was performed, which is 0.94, and adenosine was given, after which actually FFR is still 0.88. And so there was no adverse reactions, and no PCI was performed to the FFR, as it hemodynamically or physiologically not significant. So 1 week after that, we went ahead and proceeded with the transfemoral right approach for TAVR, and the deployment of a Sapien XT 26 millimeter valve was performed, and troponin went up to 110 nanograms per liter, which is high, and normal ejection fraction, and patient was DC 3 days after TAVR. So this is the data that we have, and we know to look at when should we do the timing of PCI in patient with TAVR. PCI plus TAVR in the dark maroon color actually has shown to have higher MACE events as compared to 30-day mortality, up to even 14% in some group of patients by Conradi, and whereas TAVR alone had slightly lower mortality rates, or even staged PCI is better than a concomitant PCI and TAVR. So right now what we can say at least is that it's probably better not to do them together in the same sitting. If it is possible, do one or the other. So then there's another meta-analysis. Obviously there's no single randomized trial, as I can say of right now, which is available. So meta-analysis was done by Samir Kapadia in about more than 5,000 patients. About 13 studies were included in this, and 30-day all-cause mortality between patients with and without coronary artery disease has shown that actually if having CAD is slightly worse in these groups of patients. So not statistically very different at 30 days, but if you look at the same all-cause mortality at 1 year, the patients with coronary artery disease definitely did worse than without coronary artery disease who underwent TAVR. So the prognostic impact of pre-TAVR residual syntax score, we know that people who have residual syntax score of more than 8 did worse while undergoing TAVR than without a residual syntax score of less than 8, or actually 0 syntax residual syntax score. So this is about nearly 2,385 patients where they were analyzed, and incomplete revascularization does have an impact on the outcomes after TAVR. So when you think about it, as I said, that there are 3 things that we have to talk about. One is actually the presence of aortic stenosis and coronary artery disease, and what should you consider, multi-vessel PCI, whether we should always open up the chronic total occlusions to obtain a residual syntax score of less than 8. Is that something that we should use, and whether how should we do it? Bifurcations, I mean CTO, bifurcations and rotablation, these are all high complex procedures, and whether it is advisable to do such a high risk procedure in a patient with severe aortic stenosis. And the other question is, if the aortic stenosis is significant, less than 0.5 centimeter square, and then coronary artery disease is not so significant, like as I showed you that mid-RCA of, I mean a mid-circumflex of 60% lesion, or a mid-RCA even if it is 95% lesion and asymptomatic patient, should we leave that alone because he is not having angina? And will he be able to tolerate rapid pacing at the time of aortic TAVR with the balloon expandable valve, or should we choose a self-expanding valve is something that we have to think about. So then we have very rarely patients with significant CAD and significant aortic stenosis. So those are the patients that where we really have to suffer a lot in thought process and have a heart team approach in trying to think about whether we should even put them on bypass machine and do all the procedures at one time, which we have done. Somebody with a 99% RCA and a 99% LAD lesions, and patient had significant aortic stenosis. We actually placed the patient on bypass, and we did all of them concomitantly. So in conclusion, we can say that the PCI can be performed in patients with severe symptomatic aortic stenosis without an increased risk of short-term mortality or procedural complications compared to a propensity matched patient without aortic stenosis. The problem nowadays what we are facing is that we have pushed the bar too low. We have moved away from cohort B to A, and now we are doing intermediate risk and also early TAVR, meaning moderate aortic stenosis patients with actually younger age group of patients in whom actually there may be coronary artery disease might come out later. So after TAVR, and how should we access these coronary arteries might be a huge problem. So nowadays we always recommend, if the patient has some mild to moderate disease, always do FFR in these patients and make sure that coronary artery disease is not significant. If it is physiologically significant, please do PCI prior to placing a TAVR, because as we have seen even in the recent live cases, there were problems where people could not access coronary arteries through core valves. And I mean, Ashish, you have some great presentations on CAD and TAVR where you were able to access, but I think at the recent SCAI meeting, they had a terrible time accessing the coronary arteries in a live case presentation. So TAVR alone has been shown to reduce mortality compared to TAVR with PCI. I showed you that. But concomitant PCI with TAVR is associated with better 1-year survival, though not at 30 days, with the lower MI rates than staged PCI. Incomplete revascularization has obviously, as I said, if a residual syntax score is more than 8, has worse outcomes. So at the end, my take-home points is treat the primary cause. If aortic stenosis is the most significant one, treat that. If coronary artery disease is more significant than aortic stenosis, when patient has angina, treat CAD first with PCI. And if patient becomes ischemic during TAVR, then obviously you have to first go ahead and treat the coronary artery disease. Most stable ischemic heart disease can be managed with medications, and future studies are needed to evaluate actually the need and timing of PCI in patients with TAVR. The current study that is ongoing is called Activation Trial, and we don't have any results. It has just started enrolling in about 3 years ago, and we will have to wait for the results from that. PCI post-TAVR may be difficult in some scenarios. As I said, we are treating younger patients nowadays, and so we have to be cautious and have a plan how to access these coronary arteries in the future if the patient develops CAD. Thank you very much.
Hi, I'll just go over this in a very short frame of time. I don't think this is a topic that requires a whole lot of introduction, but I think it's just important to remember a few things that I think will keep you out of trouble, and if you get into trouble, have a planned bailout strategy, if you will. So, luckily with TAVR, we have the luxury of doing a very detailed CT analysis of the patient. And so the very first thing that I highly recommend is a very careful review of the CT angiogram. And by that I mean reviewing the CT done without necessarily, even before it gets put into the dedicated software that is created, but just look at things that you find that sometimes can be unexpected. Like for example, you see in the left lower panel, can anybody take a guess at what that is in close proximity to that right common femoral artery? And that was something on a TAVR we just recently saw less than like a month ago. That's bowel and a hernia that's almost abutting the anterior wall of the common femoral. So if you were not paying attention to this large hernia and was not visible, believe it or not, on the patient when he lay supine, because it was when we saw him in the office, but it was just picked up on the CT scan, really made us realize that going from the right groin in that instance was not the smartest thing to do. So it's important to look at the CT, review it, and not just look at the aortoiliac anatomy, But like, for example, the panel on the right shows a patient who has a sigmoid S-shaped aorta in the thorax. And I mean, that's something that you want to look at and be considerate when you try to advance a sapien sheath, or even, for example, a core valve sheath into the arch, because a couple of things are going to happen. One, you're going to bias towards the outer wall if you can even get across that. And I think secondly, you'll have trouble loading the S3, for example, because I think you don't have a straight segment in the aorta. So that's like the first step I do for all cases. Look at the CT yourself. The next thing is, luckily we have these dedicated CT software programs now, whether it's Tremensio or Circle, depending on which program your institution has. These are expensive. I mean, I think the overall software to download is, I think, close to, at least in the US, Tremensio is a Dutch program, is I think $18,000 to $20,000 for a year's for sort of downloading it onto a computer, but it's well worth the effort for your institution to pay for maybe 1 or 2 computers in the hospital to have Tremensio loaded on them, so that it gives you the opportunity to not just look at the access with the dimmed background, it's shown in the left panel, but also do what's called a snake view. And that was on the right panel, the snake view of a subclavian that we accessed percutaneously, which clearly is, disease-free and of adequate caliber, and that makes a decision-making of whether or not you would go from, say, a subclavian versus somebody who had a borderline femoral access clear as night and day. The step 3 is actually during the procedure itself. So step 3 that I think is important is to use roadmap. So we typically will use the roadmap to gain access at the desired location. And the CT helps, because the CT will be able to tell you where the calcium is in the common femoral, so you can actually hit it at the desired spot. Whether you use ultrasound or not, I'm not going to quibble, but the data with ultrasound for TAVI is not clear, but the data for ultrasound otherwise for large bore arteriotomies in other areas is clear. However, it makes sense to at least have a roadmap available so that you can stick the common femoral artery under direct visualization like so. The other important tip that I think is to use a long sheet. So when you use our contralateral sheet to put a pigtail, we use a 6 French long sheet. And what that does is it gives you the ability to take an up and over angiogram without having to cross over to the opposite side for your first shot, meaning your roadmap shot. Next thing is, advantage of that is you can just slide the sheath over if you ever need to balloon tamponade the bleeding on the big side. And then the other added benefit of a long sheath is it does stabilize the pigtail in the non-coronary cusp when you're doing the case. So highly recommend using a long sheath. Sometimes, patients have artificial hips, and those can sometimes come in the way of your angulation. So taking that steep RAO shot to be able to separate out the SFA, common femoral bifurcation, to ensure that at any given time you're above, you could get into trouble. And we have inadvertently, it was done, we learned this the hard way, where an 18 French sheath was put in through the profunda, and we got the case done, but at the end of the case we had a whole bunch of bleeding and difficult to manage, because the profunda runs posteriorly and it's a really hard vessel to get good control off, and the surgical repair took much longer than what would have been the case if we were aware that we had got into the profunda before we started. A quick comment about ultrasound access. I think there's one publication from Canada that in last year looked at the use of ultrasound guided access to reduce access related complications for TAVR. My only problem with this was that their complications with just angio related access was 25%. I think that seems like a little bit outrageous. I don't think any of us have a 1 in 4 complication of accessing the common femoral artery, even if we did it blindly. So I think obviously it made ultrasound look a little better than it actually is, but I think in the right patient, I think it's quibbling whether to use it or not. I think it's operator dependent, patient dependent, and heck, it adds 5 minutes to your procedure, but if it can add a degree of safety and comfort, why would you say no? Just a quick recap on the sheet sizes so everybody understands, because I feel like there's a lot of gaming going on with industry as far as what sheet size is actually the recommended sheet for an individual valve. The Evolute R, usually everybody talks about it being 14 French, but that's really the inner diameter. The Evolute R outer diameter is 18 French. Similarly, the S3, people talk about it being 14 French. Again, it's really, you don't really have an outer diameter with the E-sheath because the E-sheath expands, but it's important to realize that the vessel needs to at least be 5.8 centimeters or almost 6.5 centimeters if you're trying to implant a 29 millimeter S3. Similarly, for Lotus and Portico, you need to fully understand what their recommended sheet size is and whether they're talking about an ID, OD, or what the actual vessel diameter needs to be to safely perform a transfemoral TAVI. What about the frequency and effect of access-related injury? Luckily, using 14, 16, and 18 French sheets is a lot better than when we first started doing this, when we had 22 and 24 French sheets in 2009, 10, and 11, when we were part of the partner series of the early first-generation TAVRs. Those complications frequently required open repair because it really meant you either had an artery on a stick or you had some really unbelievable tears of the iliac artery, typically at the external iliac and common external iliac and hypogastric junction, and those typically would be very difficult to manage even with Viabonds. But luckily the complications now are all pretty much managed endovascularly, and this is really a nice analysis published in 2016 that looked at what the effect was of access-related vascular injury and then a subsequent vascular intervention. They divided their group into patients into two groups, one that didn't get any vascular intervention and those that got a vascular intervention with a covered stent. And you can see that there was really not much difference in terms of hospitalization mortality, other than the fact that there was obviously a tendency to receiving blood, but otherwise it was a pretty benign event, which is why the STS in the recording of an endovascular procedural complication requires it to be coded as a minor vascular complication, similar to that of a failed closure device. So I think, yes, having a vascular complication is not good, but in the big scheme of things, an endovascular repair of a vascular complication is not that big a deal. Quick talk about alternative access. So we've done maybe a handful of percutaneous TAVR cases done through the axillary route percutaneously. They're also very useful if you plan on using LVADs, especially if you have a big LVAD program where we end up putting mechanical circulatory devices through the axillary artery so that the patients can get up and walk, especially in the ICU as their heart recovers. So ideally, you want to stay outside the chest. The way we do this is you get access in the femoral artery, you put a catheter into the subclavian, you take a subclavian angiogram. The one on the left, of course, unfortunately, is a patient that already had a dialysis catheter, so or actually had a fistula. That's why you see the artery and the vein in the left shot. But once you, this was a case we did recently with a TAVI, you protect the access with putting an 018 wire down the arm and leave it down there, usually like a Platinum Plus or a Roadrunner, and leave it down and leave it in the left axillary and brachial artery while you do the case. We then stick outside the chest, so there's no risk of a hemothorax and maintaining hemostasis. You can use ultrasound. A lot of the times you don't need to. You can see that I'm sticking outside the chest, and you're able to get access into the axillary artery. Once you're into the axillary artery, you dilate it up. You can use your two pre-closes and pretty much do the case as if you were doing a femoral case. Except that when we close the close the subclavian, we have certain tricks, which I'll tell you what they are. So we want to typically allow the blood pressure to equilibrate and not be in the 160 to 180 range. We use a proximal balloon over that 018 wire to ensure a dry field for the percloses to take. You could use that even for your femorals if you need. Our surgeon suggested that we use rapid pacing sometimes to lower the blood pressure. I usually would much rather put a proximal balloon rather than subject the patient to a rapid pacing run. Sushil and his group at Columbia, they leave a contralateral 14 thousandths of a wire down the contralateral side for the femorals to allow for rapid sequence tamponade if you have a failed closure device. That's one way to do that. I think was great when we had the 21 and 23 French sheaths. I'm not sure you need to do that for a 14 and a 16 or an 18 French sheath, so I don't typically do that currently. Important thing to do is at the end of the case to have a completion angiogram. The case yesterday from Eberhard Grube's lab, demonstrated that there was a stenosis. It's not unusual to have a stenosis at the access site. It's typically more common after you've used a third PERC close. It usually requires no treatment. However, there's new data that was recently published in JACC that did show that long-term it did lead to reduction in the femoral diameter due to femoral artery shrinkage from placement of a large sheath and subsequent closure. Thanks for your attention.
We're still using actually ipsilateral. We keep a wire all the time on a ipsilateral just below the large sheath. We put a 018 wire. And as you know that the TAVR becoming very routine, obviously we are taking on smaller femoral arterial sizes, and so we do end up in a problem at times. And it's as a safety wire that actually we keep it on the ipsilateral side. And that said, in our clinical trials, even using any type of covered stent was considered as a complication. Are you using a lot? Do you see at least the use of covered stents now? Or?
I think the typical plan, I think the goal is every hospital has a plan, right? So our plan is if there's a bleed, the first thing we would do is if we suspect that the iliacs are potentially going to be an issue, we will bring the pigtail after we've deployed the valve down to the aortic bifurcation, and as we are pulling back our sheath, we'll take a little angiogram and puff as we take the sheath out. If we notice that there's extravasation at the level of the iliacs in the retroperitoneal space, we'll immediately put the dilator back from the same site that the sheath was and then advance the sheath to get tamponade. If once we've done that, you have control of the case, we know that we have an issue that we have to deal with, we then will get everything lined up in terms of the up and over access, the wire across, the size based on the CT, and then we'll go ahead and plan for implanting a covered stent. If it's in the retroperitoneal space, it really doesn't matter. We'll usually use a balloon expandable stent without any concern. If there's no issue higher up and the issue is at the level of common femoral access, then we would try to refrain from putting a covered stent, especially even a Viabond for access related issues and for crush related issues. And in both those circumstances, we'll do a balloon tamponade internally. We'll first try to put a third PERC close. I don't go ahead with a fourth PERC close because if 3 don't work, I don't think a fourth's going to work. At that point, you have option D, which is either putting in an angioseal, which again, I'm not a big fan of. So then in that case, what I'll do is we'll take a balloon sized 1:1 or 1.1:1 at the level of the common femoral and do internal tamponade for somewhere between 6 to 10 minutes. That usually takes care of the problem in about 70% of the time. And if there's still active bleeding, then we make a decision of how young the patient is, how active he is, what potential morbidity might be introduced by putting a covered stent across the femoral head versus a surgical cut down and a quick repair.
I mean, we basically use the same approach. I think the only thing is if we think they're high risk for vascular complications, we actually consent the patient for a stent. So if you have it on your consent prior to the procedure, then it's not a vascular complication. So just for your database, you can maintain better, so especially if we know that we're gonna balloon dilate one and put a stent to just go through one of the groins, then all that we do pre-op in the consent. But that's the only thing.
I think with the ipsilateral access with the 018 wire, we also do the same as you were saying, balloon tamponade and then remove the large sheet and bloodless field, try the PERC close sutures. If that fails, then obviously we stent across, or if there's a perforation, then we use covered stents in both the scenarios.
And if we have an older patient, we will go and put a covered stent across, in the common femoral. But in the younger patient population, we try not to because they're going to have problems. And so then at that point, we'll just open the groin and just take care of it directly. And you can fix it pretty easily, I think, in most patients. So I think our threshold is very high to leave a stent in that position. It has to be like a 90-year-old or someone that we are really concerned, super obese patient that we think it's going to be a big problem.
So do you use a micropuncture to access?
Yes, we do.
You do?
We use micropuncture for everything, yeah.
Okay. How about you?
Yeah, again, I think I go by case by case. I don't necessarily, I mean, if it's a young patient with a good access and easy vessel with the bounding pulse, I probably won't. But if it's any concern, then I'll use micropuncture and ultrasound.
Good afternoon, everyone. And today I'll be talking on something very novel in the field of TAVR. As this technology is growing exponentially, especially in West, it has been used very widely, and India also it is slowly catching up. And it is expected that almost by 2025, we'll be doing almost 3 lakh procedures in a year. And the most common, or you can say most devastating complication which I feel are the two. One is a complete heart block, another is stroke. And the incidence of stroke is quite significant if you consider that it is almost 5 to 10% in various trials. So that is something which is very devastating to the family and others, that you do a procedure which is so important for them, and then suddenly you end up in a stroke. And as the TAVR indication is getting expanded, and we are trying to go with more and more people who are having intermediate risk, and slowly we are coming to low risk population, a stroke is something which I feel is not acceptable to anybody. And as the age group also is slowly coming down with a low risk population, so that is something which we all have to look into, that whether we can really accept a stroke in a patient who is undergoing a TAVR or not. So what are the options and how we deal with it, what is the current status, that's what I will be discussing. So why it is so important? Is it just only the morbidity part or something more than that, or what is its impact on the mortality? And this was a meta-analysis, and which shows that if 30-day mortality if a patient is having a stroke is almost 28%, which is 4 times more than a person who doesn't have a stroke, which is 6%. So that is the impact of developing a stroke in a patient who is undergoing a TAVR. Why does it happen? We all feel that it is probably because we are dilating a balloon in a highly calcified artery, and probably the debris is going out. But that is just one part of it. It is not that only the material is coming from the valve. It is from the entire region through which our valve is traversing, whether starting from iliac artery to abdominal aorta, thoracic aorta, aortic arch, ascending aorta, and then finally when we go across the valve and expand it, balloon dilate it, and we do the post dilatation and all this thing, these debris and atheroma and other materials, they go and then they give rise to a stroke in this patient. And this was a histopathology study, and if you can see here, all sorts of material are there in this, whether it is a thrombus, but most common is a thrombus. Even they have found small bits of foreign body material which is a part of the balloon or a catheter which has been taken. So all sorts of material are found in a patient when they analyze this debris which was captured in the embolic protection device. What exactly is the incidence? If you go by historical, partner A, B, they had almost 5.5% in comparison to the surgical stroke rate, which was almost 2.5% in that situation. This is this study again, it shows that almost similar stroke rate we are seeing in most of the trials, which is hovering around 3 to 5% at the current level. The TVT showed that the stroke rate has in fact come down to 3% in all comers, but if we compare this with the data which was presented in the embolic protection device, it was again 9%, which was supposed to be done by one of the best people. So we still are hovering around a range of around 5 to 6% stroke rate in people who are going with it. But that is what is a clinical stroke rate. But if you do an MRI, we will be able to pick up a lot more number of events which are happening than what is actually being observed clinically. So when you do an MRI, diffusion wave MRI is done, you can see that almost 80-90% people do have a lesion which is developed after TAVR. So that is something which is very diverse. That means these number of patients clinically manifest stroke rate is only 5%, but if you do an MRI, you are seeing almost 80-90%. So why this discrepancy? So probably these are considered as a silent stroke, and over a period of many of these strokes, these lesions which are detected in MRI, when they do a second MRI, they improve. But the concept and the implication of silent infarct cannot be just ignored by this, some improvement in some of these lesions which are later on improving. So this concept of silent infarct is slowly coming up in a big way, and people are realizing that it is something which is not to be ignored. Silent infarct is a definitive entity which has to be taken seriously. And the new definition of ACC/AHA has in fact incorporated it. And what it says, it's an emerging or neuropathological evidence of CNS infarction without a history of acute neurological dysfunction attributable to the lesion. And these are well recognized to be associated with several adverse neurological and cognitive consequences: impaired mobility, physical decline, depression, cognitive dysfunction, dementia, Parkinson's disease, Alzheimer's disease, and all these things in the future. What is its impact? There were two important studies which were done to assess whether silent infarcts are really important. One is a Framingham study, and if you see, the incidence of dementia, stroke, and even death has over a period of time in those patients who had silent infarct has been much higher when they followed them up for over a period of time. And there was another study from Rotterdam which again assessed the cognitive decline, and in the conclusion they found that the presence of silent brain infarcts at the baseline, it more than doubled the risk of dementia, and the presence of silent infarct on the baseline MRI was associated with a worse performance on neuropsychological tests and a steeper decline in global cognitive function in these situations. So that is what we are looking at. If you are just ignoring the silent infarct, then we are probably missing out on these patients. So that is also something very important, because if a person who undergoes a TAVR procedure at the age of say 60, and over a period of time he starts developing all this dementia and cognitive dysfunction, that is something which, if we can prevent it, there is nothing like it. When they looked at how and when is this showers of embolization or shower of strokes are happening, it was found that majority of these are happening in first 2 to 3 days time. Between first 3 days is the maximum time when you have maximum release time for this embolic debris. And it is many a times we thought in the initial stages that it is probably the people who are not experienced, they are not able to handle the device when it is going across, and probably that may be the reason. But there was a beautiful study which showed that even after adjusting for it, the experience of the operator did not change the ultimate outcome of stroke in this patient. So if you are an experienced or a relatively less, I can't say about the inexperienced person, but if you are an experienced, a highly experienced and a relatively less experienced, the incidence of stroke rate is almost same. So it may not be related to the technical aspect always, and in all count you cannot just ignore that always. So what are the options we have? Two things are very important. One is to maintain the anticoagulant properly, because the most important debris when they analyze it was a thrombus. So if you are maintaining your anticoagulation properly during the procedure, that is something, then you will probably be able to reduce some of it. People are suggesting that we should go ahead with using other anticoagulants only just with aspirin, whether it is enough or we can go ahead with that is something to be debatable. But I will be concentrating more on the device which is used, that is the embolic protection device. We have 3 devices: TriGuard, Umbrella, and the Sentinel. Out of the 3, the Sentinel has already got the US FDA approval. I think in June 2017 it got the approval. So little bit on that. It's a filter device basically, because we are all used to filter devices. The other 2 are not filter devices, they are basically deflection devices. So here you have 2 filters which capture and remove the material. Its pore size is 140, and it is passed through radial access, and the manipulation in the outer arch is relatively less. The ease of implanting is very good. In the Sentinel trial, they said ki it takes just 10 to 15 minutes just to deploy the device, and the fluoro time is also quite less. And the safety and efficacy was already proven by the initial trials of the ClearTAVI and other trials. They have clearly showed that it's a very safe device. And you can see what are the materials which are captured. In the Sentinel trial, they said ki almost 99% of people who were put on filter, the device captured something. So that shows how important is the device. And these are the devices, and these are the MRI images which shows on the left side. You can see it is the control group, whether there is no filter. The volume and the lesion numbers are quite high on the left side, and when on the protected group, you can see the volume is quite less. The lesion is also, the number of lesions are also less. Let us look into some outcome data. We don't have very robust data, but few trials which have been done only with 30 patient, 40 patient. But the Sentinel trial had the highest number. The randomized trial had almost 300, and then there was some other trials which almost pooled to almost more than 1,000 patients have been implanted on this Sentinel trial data. So overall, if you see in these three, CleanTAVI, Mistral and Sentinel, if you do this analysis, you find that definitely those who were on filter had a better outcome in comparison to those who were not on filter. If you look at the day wise, so in all the three, the control group definitely had a worse outcome compared to the protected group. In the ULM Sentinel study, which was basically a single center study from Germany, which had the highest number of 560 patients were continuously evaluated, there they found that the Sentinel group had only 1.4% 7-day risk of stroke, and there was almost a 70% reduction in the stroke rate, and 7 days all cause mortality and stroke rate was reduced by almost again 70%, which was statistically significant. If you look at the combined analysis of the trial which was presented to the US FDA and this ULM study, then if you again do the pooled analysis, there was almost a 60% reduction in the stroke rate and a combined event of stroke and mortality in this subgroup of patients. So that clearly showed that using this device definitely had a better outcome compared to not using a device. The other two devices which are there are the umbrella, which are implanted in the aortic arch, and the TriGuard. So we had the study with TriGuard or the Deflect 1, 2, 3. So they have suggested that these are pretty safe devices, but they don't have robust data to suggest whether they are showing statistically significant improvement or not. If we combine all the available data, and there was a good analysis which came in JAC 2017, which showed that when the patients were compared with filter and without filter, definitely there was definite improvement in patients who are on filter group. But it is not that you use a filter and everything is rosy. There are some limitations, there are some drawbacks, and there are some concerns also. So what are the limitations we are? First and foremost is there is no consistent definition of stroke, infarction and silent infarct, for which is very critical for interpretation of clinical research trial. All the trials had their own way of interpreting the stroke rate. And even among the neurologists also, if you see, there are three different stroke definitions which are there. One is the Neuro ARC definition, one is the American Heart Association definition, another is the Valve ARC2 or a definition which is again going to be updated. So if you have these three different opinions, then definitely if the trial is taking one definition, they will have a different outcome than a trial which is having another A. So there has to be a consensus in exactly what we are trying to look at, and we have to assess the neurocognitive function. That is also very important, and it has to be done by a proper neurologist. Then when you use an MRI, then there is a confusion whether you should use a 1.5 Tesla or a 3 Tesla, because if you increase the Tesla, then you are picking up even some minor lesions. What is the impact of these minor lesions? There is no clear answer to this. And what is the protocol for doing this MRI? How frequently it should be done, when it should be done, whether it should be done on day 1 or day 3 or day 7. So there is no clarity or standard protocol which is being followed by different. And then there is a issue of testing the neurocognitive function. So there is a large observer variability in this. So what is the protocol to be followed in all across the subgroups? So that is where you will have a uniformity of data which is coming up, and then you can analyze and interpret that. Then third question is, There was a subset which was done in the past, that is when the stroke rate is also there in patient who is undergoing surgery, but the trial which was done in surgery with protection, without protection, did not show any benefit. And we know that the stroke rate is only 3% in surgery patient. So if that level of patient, that the stroke rate is so low, and there if you do this comparison of protection and without protection surgery, there was no benefit. So how are we expecting that in a TAVI patient, where again we are expecting a stroke rate of 3%, whether there will be improvement or not? So this is something which is a gray area. So in conclusion, I will say that stroke in TAVR is a real issue. There is a large number of patients who suffer from silent infarct that cannot be ignored. The safety of EPD during TAVR is definitely proven beyond doubt. They are pretty safe devices. Some of the EPD trials definitely showed to reduce the number of periprocedural infarct in the brain, but we need a large data to recommend its universal use and change the terminology from TAVR to a protected TAVR. Thank you.